Diabetes mellitus is defined as a clinical syndrome which is characterized by hyperglycemia due to absolute or relative deficiency of insulin. An absolute deficiency or insufficiency is when 80 to 90% of the islet B cells are destroyed. Destroyed how? By T cell mediated autoimmune destruction of beta islet cells. Autoimmune, so there is a genetic pre-susceptibility. We have HLA-DR3, DR4 on chromosome 6. Insulin deficiency, basic problem in diabetes, hyperglycemia, metabolic sequelae. What metabolic sequelae? Before that, understand what is causing the hyperglycemia. You know that in type 1 DM insulin levels are decreased, and insulin, which normally physiologically used to inhibit hormone sensitive lipase and prevent the breakdown of fats and proteins. Since it is deficient, now there is going to be increased lipolysis and proteolysis. As a result, in type 1 DM, there is going to be weight loss. Increased fat breakdown will lead to increased free fatty acids, glycerol, and ketogenesis. Now, free fatty acids go to the liver, and here they will undergo gluconeogenesis. Less insulin also caused less glucose uptake by the muscle and the liver. Less insulin also caused increased glycogenolysis. It is absent counteraction to the effect of glucagon. All these three things leading to hyperglycemia. Now, if glucose increases in the blood, it will go out through the urine, which will cause glycosuria. Osmotic force pulls out all the water. So you will have dehydration. Dehydration sensed by the juxtaglomerular apparatus, and it causes RAS activation. And in RAS activation, you have increased aldosterone secretion. So secondary hyperaldosteronism, which is going to cause potassium loss in the urine. Up till now, we had weight loss, we had secondary hyperaldosteronism causing potassium loss, and we had dehydration as the symptoms. Now, hyperglycemia also directly causes increased thirst, increased polyuria, nocturia, fatigue, and infections. Weight loss and plus or minus ketoacidosis is important to remember. Most commonly, type 1 diabetes is seen in child and adolescent, way more than adults. Oh, and I want to tell you about this very weird phenomenon called the dawn phenomenon. Imagine you have a type 1 diabetes patient who is on insulin. Now, this patient goes to sleep and wakes up in the morning. There is a sudden increase in cortisol and growth hormone. This causes a sudden drop or waning effect in the isophane insulin that was given at night. Isophane drops because of this, and insulin drops means glucose is going to increase, and glucose has increased even though bro was fasting, which is why this is a very weird phenomenon. It's called fasting hyperglycemia. So you got that? Now, type 2 diabetes is very easy to understand. So your muscles and liver normally have insulin receptor. When insulin comes and binds to these receptors, it activates a pathway known as PI3-AKT pathway. Now, inside these muscle and liver cells, there's something known as GSV, or the glut-4 storage vesicles. On activation of this pathway, what happens is that these GSVs come and translocate to the surface of these muscle and liver cells. So in a sentence, through this pathway, insulin causes glut-4 exocytosis. And glut-4 exocytosis is very good and very healthy for us, because that means the glucose is being taken by our muscles and liver, and if that happens, it won't be elevated in the blood, and it won't be converted into adipose, which is what is healthy and which is what we want. Exercise increases AMP activated protein kinase, which stimulates this pathway, which is good for us. In type 2 diabetes mellitus, there is some sort of a resistance or a blockage to this signaling. Therefore, these GSVs remain inside. In a very obese patient, there is a lot of adipose tissue which has a lot of free fatty acids. Now, this gets overwhelmed and the free fatty acids spill into the blood. And in the blood, their metabolites like DAG are going to cause activation of serine or threonine kinases like protein kinase C, and that is directly going to cause resistance to this pathway. These kinases can also come from mitochondrial dysfunction, chronic abdominal obesity, and low-grade inflammation, and reactive oxygen species due to stress. I hope you understood the pathophysiology.